I've opened more than 2,000 chests in my career. I've held beating hearts in my hands. I felt the difference between a healthy heart and one quietly losing the battle. For years, some of the worst damage I've seen on that operating table wasn't caused by poor diet. It wasn't smoking. It wasn't genetics. It was caused by medications, pills prescribed with the best intentions that were quietly working against the heart instead. I'm Dr. Kevin Adewale, cardiothoracic surgeon. 25 years operating on hearts that reached the point where surgery was the only option left. Today, 5 specific medications that millions of people over 60 take every day, and with a 7-minute appointment almost never covers. This is not about scaring you. It's about giving you the information you need to have a better conversation with your doctor. After 60, your body processes aging bodies and polypharmacy medications differently. Your kidneys filter more slowly. Your liver metabolizes drugs at a reduced rate. The average American over 65 takes 4 to 5 prescription drugs simultaneously. Some take 8 or more. Each drug was tested individually, approved individually. What happens when you combine 3 or 4 in a body already working harder than it used to? That question almost never gets answered in a standard appointment. I want to introduce you to someone. I'll call him Clarence. 74, retired electrician. Sharp, careful, did everything right, walked 2 miles every morning, watched what he ate, had every reason to expect his health was under control. Clarence came to me after his second cardiac event in 18 months. Exhausted, not tired, exhausted, the bone-deep kind that doesn't lift after a full night's sleep. Muscle cramps woke him at 3 o'clock in the morning. His thinking had slowed in ways that frightened him. 3 doctors, same answer every time. Clarence, you're 74. This is normal. 2 years of that. When I reviewed his full medication list, every drug, every dose, I saw the problem within 5 minutes. Not one problem, 3 simultaneously for 2 years. We'll come back to Clarence because how his story ends is the whole reason I'm making this video. Pill 1. Statins and CoQ10, now the 5 pills. Statins. If you're over 65 in America, roughly 1 in 3 chance you're taking one right now. Atorvastatin, rosuvastatin, simvastatin. The names change. The mechanism is the same. Statins save lives. For established heart disease, the evidence is clear. I've prescribed them thousands of times. I stand behind that. But there is a consequence buried on page 14. Statins block something called the myelinate pathway. That pathway doesn't only produce cholesterol. It also produces CoQ10, coenzyme Q10, and that distinction changes everything. CoQ10 is the fuel your heart cells run on. Like engine oil, without it, the engine runs rough and eventually it wears down. A 2005 meta-analysis replicated multiple times showed statins drop CoQ10 blood levels by 30 to 50%. 30 to 50% depletion in the organ that needs it most in a real patient. Fatigue that doesn't respond to rest, muscle weakness, mental fog. Measurable reduction in cardiac function in a significant subset. Clarence had been on a high-dose statin for 2 years. 2 years of his heart running below capacity. And here's what should make you angry. CoQ10 testing is not standard practice, not in the guidelines. Some insurers won't even cover it. CoQ10 is over the counter. No patent, no profit margin, no financial incentive for anyone to add it to the standard protocol. I'm not calling it a conspiracy. I'm calling it a system with no incentive to ask an inconvenient question. The fix 100 to 200 milligrams of CoQ10 daily. The Q-Symbio trial showed measurable improvement in heart failure patients who supplemented it. Should I be supplementing CoQ10 alongside my statin? That's the question. Write it down before your next appointment? Not should I stop just that. Pill 2. This one surprises people. It doesn't look like a heart medication. And that's exactly why it's dangerous. Ibuprofen, naproxen, diclofenac, the NSAIDs over the counter, cheap in every medicine cabinet in America. Most people think ibuprofen reduces inflammation. Inflammation is bad for the heart, so it must be neutral at worst. That logic is exactly backwards. NSAIDs block COX enzymes, but COX-2 specifically produces prostocycline, your blood vessel's natural protector. Keeps vessel walls flexible, prevents dangerous clotting, block COX-2, and you remove that protection. Simultaneously, regular NSAID use raises blood pressure 3 to 5 millimeters of mercury on average. 3 to 5 points sounds modest. Over 60 with arterial walls already less elastic. That chronic increase raises stroke risk in ways that accumulate over years. The FDA put a black box warning on NSAIDs in 2015, not just for stomach bleeding, specifically for heart attack and stroke on the label right now. Clarence was taking ibuprofen every single day for 2 years. His doctor knew. Nobody flagged the cardiac risk. For chronic joint pain, ask about topical NSAIDs. Gels deliver the same anti-inflammatory effect locally with 90% less systemic absorption. For chronic background inflammation, curcumin with piperine has real evidence. 2 to 3 grams of omega-3 EPA and DHA daily has better cardiac data than most people realize. The REDUCE-IT trial, 25% reduction in major cardiovascular events with high-dose omega-3, that is a number worth knowing. Don't stop a prescribed anti-inflammatory without your doctor. The goal is a better conversation, not self-prescribing. Pill 3. This is the one that took medicine an embarrassingly long time to recognize because it looks nothing like a cardiac drug. People buy it without a prescription. Take it with their morning coffee. Never think twice. Proton pump inhibitors. Omeprazole, pantoprazole, lansoprazole. Roughly 15% of the entire American adult population takes them. Many for years, some for decades. Here's what gets buried. Your stomach acid isn't the enemy. It's a gatekeeper. You need it to absorb vitamin B12, block that acid long-term, and you block B12 absorption. Not partially, almost completely. Why does a heart surgeon care about B12? Because it's essential for metabolizing. Homocysteine, an amino acid that when it builds up directly damages arterial walls. Elevated homocysteine is an independent risk factor for cardiovascular events. Comparable in some studies to high cholesterol, almost completely ignored in standard workups. A 2013 study in the journal Gut found long-term PPI users have B12 levels 30% lower than non-users in a population already losing B12 absorption naturally with age. After 60, your stomach produces less intrinsic factor. Drug-induced deficit on top of an age-related one. B12 deficiency looks like fatigue, memory problems, a tingling in the hands and feet that creeps in so gradually you barely notice at first. In severe prolonged cases, irreversible neurological damage from a heartburn pill taken for 10 years because nobody checked levels annually. But PPIs don't stop there. They also deplete magnesium involved in over 300 enzymatic reactions in the human body. For the heart, magnesium regulates the electrical signals that keep your heartbeat steady. Deficiency is directly linked to arrhythmia, to cramps at 3 in the morning. Clarence's B12 came back critically low. His magnesium at the bottom of normal range, technically within range, so nobody acted on it. If you're on a long-term PPI, ask for B12 and magnesium levels. Ask whether there's a plan to eventually taper off for B12, methylcobalamin. 100 micrograms sublingually under the tongue. Bypasses the absorption problem entirely. No stomach acid required. For magnesium, completely 24 milligrams, 400 milligrams daily. Far better absorbed than magnesium oxide found in most cheap drugstore bottles. Don't stop a PPI abruptly. There's a rebound effect. Acid surges back harder than before. You feel worse and go back on the drug. Taper gradually. Statin depleting CoQ10, NSAID removing vascular protection. PPI blocking B12 and magnesium. All three in clearance simultaneously. 2 years. Nobody connected the dots. Each specialist saw their piece. Nobody asked what the combination was doing over time. 2 more pills. And these are where most physicians, myself included, had significant blind spots for years. Pill 4 involves a medication that prevents dangerous clots while quietly accelerating something I've seen with my own eyes on the operating table. And Pill 5, That one involves a recommendation I made myself for 15 years that the data now shows may have been wrong. I'll tell you exactly what I told my own patients when I finally understood what the data was saying. And it wasn't a comfortable conversation. Stay with me. Pills 4 and 5. Number 5, especially, that's the part that changed how I practice medicine. Pill 4, Wherein. Around since the 1950s. Still, one of the most prescribed anticoagulants in patients over 65. Atrial fibrillation, deep vein thrombosis, mechanical heart valves. Wherein is standard care for millions, and it works. It prevents dangerous clots. It prevents strokes in AFib patients. I'm not disputing that. But here's what the 7 in Ute appointment almost never covers. Wherein works by blocking vitamin K, but there are 2 forms of vitamin K and warfarin cannot tell them apart. K2 activates a protein, whose sole job is to prevent calcium from depositing in arterial walls and direct it toward bones instead. Without K2 activity, calcium drifts. It settles into vessel walls. Arteries become rigid and calcified like pipes slowly filling with mineral deposits. Wherein blocks K2 right along with K1, so while it's preventing dangerous clots, it simultaneously removes the body's primary defense against arterial calcification. A 2019 study in the Journal of the American Heart Association, long-term Wherein users showed significantly accelerated coronary artery calcification compared to matched patients on newer anticoagulants in patients whose doctors were actively trying to protect their cardiovascular health. As a surgeon, I have seen what heavily calcified coronary arteries look like. The calcification makes everything harder. The surgery, the recovery, the long-term outcome. Does this mean warfarin patients should stop their medication? Absolutely not. Untreated atrial fibrillation carries roughly 5% annual.